Hi, my name is Chase O'Leary, and today I'll be performing a detailed analysis of a bodyweight squat and a push-up. So the purpose of this analysis is to assess movement quality, identify compensatory patterns, diagnose underlying impairments, and recommend targeted corrective strategies. So for the first assessment, I instructed my client to perform 5 consecutive repetitions of a bodyweight squat using sagittal and frontal plane recording. I conducted both real-time and slow motion analysis to evaluate critical joint angles, segmental alignment, and force distribution. Some key observations from seeing in the frontal plane. There's a medial displacement of the knees, indicative of dynamic knee valgus, suggesting weakness in the lateral hip stabilizers. And then when we look in the sagittal plane, excessive anterior trunk lean coupled with limited hip and ankle dorsiflexion range of motion, indicating possible compensatory strategies for limited mobility. Next, assessing the push-up in the anterior and sagittal view. The client was instructed to perform another 5 reps at a controlled tempo to observe scapulothoracic and lumbopelvic mechanics. My primary findings included pronounced anterior pelvic tilt and lumbar extension, signifying core instability, along with scapular winging during the eccentric phase. And indicative of the serratus anterior weakness, along with excessive humeral abduction, exceeding 60 degrees, increasing shear forces on the glenohumeral joint. So the squat is a multi-joint closed kinetic chain movement essential for lower body strength, neuromuscular control, and functional independence. It's a compound movement that includes multiple joints and multiple muscles. Optimal mechanics include synchronized flexion of the hips, knees, and ankles, and a neutral spine, and maintenance of the center of mass within the base of support. The push-up is a compound closed kinetic chain movement as well, emphasizing upper body extremity strength, scapular stabilization, and trunk rigidity. Normal execution requires proper scapulohumeral rhythm, isometric core engagement, and maintenance of a neutral spine throughout both the concentric and eccentric phase. I assigned a performance rating of a 5 out of 10 for the squat based on the observable kinetic chain breakdowns, notably valgus collapse and compensatory trunk patterns. These impairments increase the risk of patellofemoral joint stress and lumbar strain. And for the push-up, I rated it a 4 out of 10 due to loss of lumbopelvic control, insufficient scapular stabilization, and suboptimal arm positioning, predisposing the client to shoulder impingement syndromes. And then for the diagnosis of impairments for the squat, the primary impairments diagnosed are hypomobility of the ankle dorsiflexors, which would be the gastroc and soleus, and hyperactivity of the hip adductors, inhibition of the gluteus medius and maximus, and weakness in deep core stabilizers. For the push-up, key impairments include weakness of the transverse abdominis and global core musculature, scapular dyskinesis resulting from the serratus anterior inhibition, along with overactivation of the pectoralis minor and upper trapezius, and neuromuscular inefficiency at the scapulothoracic joint. Correcting these deficits is essential to restore biomechanical efficiency, optimize performance, and reduce injury risk. And this concludes my analysis, evaluation, and diagnosis of my final practical. Thank you.